Hello, I'm Jeffrey Birch. I'm here in my home studio in Eugene, Oregon, here in early January 2025. And I'm going to be talking today about work that I've developed over many years for working with joint capsules, bursa walls, and the environments that tendons live in, basically synovial membranes and associated structures. This has been a less explored area of the connective tissue matrix in our bodies, and it turns out to be really important. So here's the deal. Joint capsules attached to bone on each side of the bone, they make a complete circuit, bone 360 degrees around the joint. And they don't attach to the bone right at the edge of the joint surface. They always attach some distance back on the bone, so that the same synovial fluid, extremely slippery substance, synovial fluid is actually the most effective lubricant known to mankind, is not only between the articular cartilage, but it's between the joint capsule and the periosteum of the bone. And why is this important? Well, joint capsule material has limited stretchiness. We wouldn't really want it to be too stretchy. And so in order to have an adequate range of motion, since each little length of joint capsule isn't very stretchy, you need more joint capsule to get enough elasticity for a joint to move. So that's why, in reverse engineering here, why it looks like joint capsules don't attach right at the edge of the white cartilage, but some distance back on the bone. Okay, so years ago, I was looking at some pictures of hip joints. I needed them for another class I was teaching. And this led me to realize how far out the neck of the femur the joint capsule attaches. So on this skeleton, here we have a demonstration of the joint capsule, and you can see over here on this side, here's the edge of the joint, but effectively the joint capsule attaches all the way out at the far end of the neck of the femur. And on the pelvis side, it attaches about this far in on the bone. So you can see this run of joint capsule. And the thought crossed my mind, any place where you have a lubricated glide plane in the body, you also have an adhesion opportunity. This applies to the dural tube in the spine. It applies to organ glide planes with their synovial fluid, serous fluid around them. So I wondered, does such a thing exist in a hip joint? And I started mobility testing that in my clients. What I would do would be to sink in, hook the joint capsule, and ask, can you glide over the bone underneath? And what I found was that all of my clients had some degree of hip joint capsule adhesion, ranging from a little spot someplace to the whole darn thing, with, as you can imagine, significant reductions and distortion of movement at the hip. And then over time, I worked out ways to liberate that, to restore that glide plane. Well, of course, we have a few hundred other joints in the body, so I began exploring this with other joints. Is the same thing true in other joints? And while no other joint has as long a run of capsule over periosteum as the hip joint, all synovial joints have some. And it turns out that such adhesions are really, really common. Basically, most joints in most people's bodies have some level of adhesion to them, which is limiting and distorting ranges of motion. And over time, I worked out how to access all of the joints in the body, all of the synovial joints in the body, and how to assess to a very fine scale, 1 millimeter scale very often, where these distortions are, and then with low force techniques to free them and restore the glide in there. Well, after a little time, I realized, there are more synovial structures in the body. We have bursas. The walls of bursas are made of exactly the same kind of membrane as joint capsules, but they're not so intimately related to joints. So it's like you have a capsule with this exactly the same lubricant inside. And these are in the body are tucked into places where there are things we really don't want to have rubbing on each other. So the body has put a little bursa in between, which can roll in between, mitigates the friction, facilitates the glide. But we bang bursas and we overuse them and they get roughed up. And then our friends, the fibroblasts, are coming along to tear out the old damaged fiber and lay down new fiber. And they have kind of a tendency to get overexcited about the whole thing. So that while they're putting new fiber into the wall of a bursa, unfortunately, some of the fiber often grows through to the other side, so the bursa doesn't roll anymore. It's kind of nice that it's still tucked between things that we don't want to rub on each other, but now instead of facilitating glide, it's preventing glide. Tom Myers has described how most bursas that he looks at in anatomy are filled with fuzz, as he calls it, so that he even questions the existence and functionality of bursas. But it turns out that once you discover such fibrosity in bursas, it's really not very hard to disrupt that fiber and restore the glide in it. I'll demonstrate some of this for you today. And then I wondered, are there any more synovial structures in the body? And I recognized that some portions of some, but not all tendons, are in tubes surrounding the tendon of exactly the same kind of material with exactly the same kind of lubricant. And so I took a look at those, and sure enough, we have adhesions of tendons to the tenosynovial tube, as we call it around them. And so I worked that out for all of the hundreds of tendons in the body to restore mobility there. We work with all kinds of other structures. People who worked with muscles for a long time, people discovered fascia and recognized that it's important to work with, working with the serous fluid lubricated organ glide planes and taking out their adhesions is important. And of course, working with the meninges, dural tube and cerebral meninges is extremely important. But here we have a new frontier that's highly productive for restoring movement and position in the body. So I'll demonstrate some of these things for you. Damien is with us here this morning to assist me with this. And I'm going to work first with her knees. Knees are lovely big joints, and some of the important things we need to see are nice and near the surface, so they make a good first demonstration for this kind of thing. So Damien, if you would just come lie on your back on the table. I have a prop with me. It is a jar lid. But the method to my madness will become clear soon. Okay, so a good first step in working with joint capsules is to do some mobility testing at a large scale of the joint. So I'm going to just bend this knee up, allow me to move your leg, and let's see what it does. Pretty good as knees go. Toward the end, like right here, I can feel the accumulation of it taking a little more effort to move it, and I'd like it to eventually be able to go a little bit farther. Let's see what the other one looks like. And this one, you see, goes more easily and farther than the left one. Okay, so I'm going to work on this one this morning. Just looking at knees, I can see that this patella is held a little bit medial in here, and I don't immediately know what that is, but let's look at that from a movement mobility testing perspective. I'm going to try to push it more medial, and it'll go, and I'm going to try to push it more lateral, and it won't go. So not only does it sit more medial, but there's something holding it medial. If I do that more slowly, I can feel that it is restrained on this side rather than running into something on that side. Now, I've often likened kneecaps to little hockey pucks. They're a little low profile cylinder. And that's where my jar lid comes in. It's this, sort of a Sasquatch kneecap. And of course, with the whole knee, there's joint capsule spanning bone to bone all around the knee, except in the front, there's a kneecap sitting here. So what happens to the joint capsule is it attaches to this outer perimeter of the kneecap on this medial side and also over on the lateral side. This means that joint capsule should be free to glide over the wall of the kneecap on the side. And I'm right away suspicious that we have joint capsule adhesion on the medial aspect of the kneecap. I'm going to look at the lateral aspect. What I'm going to do is sink in here, and I want to try to move joint capsule over bone. It's important that I sink deep enough. Just moving the skin doesn't count. I have to go down to where it feels like I'm pushing into the bone. And I grab the joint capsule, it glides. Uh-oh, little sticky spot, and glides. So there's a little sticky spot right there. Let's see about this lateral aspect of it. Sticky, 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 wahoo, down here it glides. So indeed, there is more capsular adhesion on this medial aspect of the patella. All right, well, let's liberate that. So I'm now again going to sink down to the level of the capsule, and I'm going to try to move the capsule over the edge of the kneecap. And it doesn't want to, but it's kind of like if I get a hold of the fabric here and get it to glide on what's underneath. It's a low force, shear force between the two. So there we go. And that little part now glides. Let's move up a finger width. Sinking in, grabbing the joint capsule, trying to glide it superior over the bone underneath. There it releases. And there it releases. And there it releases. Let's go get this little one on the lateral aspect while we're at it. It's right there. And that one didn't have nearly as good a glue in it as the one on the medial side. Not gliding is not gliding, but this was kind of a glue stick version of adhesion, whereas this was more white glue over here, but we got them freed up. Well, let's see what the big picture of movement looks like now. It goes farther with less effort than before. The kneecap doesn't sit as medial as it was before, and if I try now to mobility test it medially, it does that. If I try to mobility test it laterally, that's better than before, but not fabulous. I'm suspicious that there may be some adhesion along the joint line, particularly on the tibial side of this joint. So identify the joint line, coming the finger width superior to that. How well do you glide? Glidey, 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 glidey. Let's go down on the tibial side. Uh-oh, sticky spot, sticky spot, sticky spot. Right, so let's free up these guys. Again, sink in, grab the joint capsule, drag it anterior. There we go. All right, and now let's take a look again. And now the patella can displace significantly more laterally than before. Let's look once again at the big picture of movement. It's even less effort to move it than before. So there's an introduction to how we work with joint capsule adhesions, how we assess for them, and how we release them on a knee, which is a relatively easy place to see that. But we've also got some bursas in the neighborhood, so let's start to look at those. Just under the skin, there's a bursa on the front of the knee. Oh, poor bursa. It lives out here in the front of the knee. We bang our knees, stuff happens. So, similarly, I'm going to sink in here on the front of the kneecap, hook the outer wall of the joint bursa capsule, and ask, how well do you glide? And the answer is, not recently. So, very similar to what we were doing down below, I'm going to stabilize the kneecap. I'm going to sink into the outer wall of the bursa, and I'm going to make a medial shear load on it to free it up from what was underneath. and now it glides better than before. There are a couple of more bursas in the neighborhood. Just the patellar tendon, delivering the force to the quadriceps muscles, attaches to the tibia at the tibial tuberosity here, but it travels over bone just superior to that, the top of the tibia. And this is a very powerful set of muscles with most of the weight of the body on it. So there's kind of a frightful friction potential there. So we have a bursa in there to mitigate that. So I'm going to grab the patellar tendon here deeply and ask, can you glide over the bone underneath? And the answer is no. And also, I can feel positionally that this bursa was rolled medial and then stuck together inside. That's inconvenient. We must fix this. So, again, I've effectively got a hold of the outer wall of the bursa using the tendon as a handle. That's most of it, but there's still a little spot, sticky spot, inferior medial. There we go. Now that moves better. There's a very interesting similar bursa up here under this portion of the patellar tendon. Four muscles, the quadriceps, converge into a single mass, and the upper part of the tendon glides over the inferior end of the femur here. And again, big friction potential. This is an atypical bursa. It's not a separate sac. It's actually a flat tongue-like extension of the knee joint capsule up under here. There are a couple of other examples of that in the body. One in the groin and one under the deltoid muscle. So similarly here, can you glide? You'd go with nowhere. All right, so again, putting a gentle shear force. I'm exaggerating what I'm doing. That's the direction of it. But initially, there's almost no movement of shear through that bursa. There we go. And this corner of it's still a little sticky, so I'll come down there. There we go. All right, let's look at big picture of movement of the knee again. Whee, fun with knees. All right, so there's a demonstration of working with joint capsule and bursas. Again, the processes are similar for all other joints and bursas in the body, with variations on exactly how we access it depending on the anatomy. I'd like to look now at tendons, and for this, we're going to work with hands. So, Damien, if you would come up and come on over, have a seat here facing the table. Adjust the height of that stool for your comfort. And I'm going to bring this table up a little bit. And we're going to work across the table playing hand therapist here today. Okay, so this hand, first I just want to look at wrist flexion. And it goes about that far. Pretty good, we like that. Going this way, extension looks pretty good. But what I want to know next is how well these extensor tendons are gliding. So what I'm going to do is I'm going to use up the length in those available length in those tendons, and then I'm going to flex the wrist. If the tendons are gliding well, this should not affect the flexion of the wrist. But what we see is much diminished flexion of the wrist, which tells us that one or more of these tendons is stuck to something that we wish it would glide upon. All right, who is it? So I'm going to fold just the fifth finger in. And that does not interfere with wrist flexion. Let's try the ring finger. Aha, that one's involved. But do we believe that's the whole story? Oh no. Often it's a conspiracy of more than one, so let's go see. This one? No. How about this one? How interesting. Index and ring fingers. Is thumb extensor involved in this? Nope. So we have two extensor tendons that are involved in this. Now there's a fine collection of little muscles in the forearm that operate the hand and fingers, and a great many tendons that come past here. And these tendons for the fingers attach to the distal phalanx, and so they run over everything in between. So what we're going to do is extend this wrist and finger, and from this position I'm going to start folding just the distal phalanx in, and then the proximal interphalangeal joint, and I can see right away that there's drag right here. This tendon is not gliding past here. So again, I'm going to use the distal phalanx as a handle because that's where the tendon inserts. I'm going to stabilize the tissue that the tendon is stuck to, and I'm going to gently pull on this. And there we go, I got that one free, but it's rarely one spot. So let's see, let's try this again. Extend fully. We have another one right underneath the lovely wedding ring here. So same idea. Stabilize the tissue that the tendon is stuck to. Pull on the tendon using the distal phalanx. Okay. And see, how are we coming along with the big project here? Oh, a lot. But let's look and see if there is any more. There's a little sticky spot right here. Not too bad as this thing goes. Sometimes there'll be a dozen spots along the way. There we go. Now, again, fully flexing this finger, it no longer interferes with that. Let's look again at this one over here. This one is still in the way. So let's sort out this one. Again, starting right here with in full extension with the distal phalanx. And our first adhesion is right there. And you saw the little quick movement there. That wasn't something I did. That was the moment of the release of the tendon. So the force that I was applying allowed it to move quickly. And there's the next sticky spot. There we go. And there's one here. I hope you can see this drag on the tendons. It's in the camera here. It's kind of subtle. Right there is the next one. See how it's pulling the tissue there? So I'll get a hold of that tissue adjacent to the tendon. And again, start folding, start flexion from the distal end. There we go. Anybody else? Yes, there's a sticky spot right here. This is typical. All right, that's looking better in a lot of ways. Let's look at it again in this way. I'm going to curl this finger in, and now we have full flexion of the wrist. So this is a demonstration of how we can proceed with tendons. And again, that's relatively easy to see in the hand. We started with the knee today, and certainly there are tendons with the knee. We talked about some tendon in the front, and there's a good collection of tendons in the back side of the knee, but it's easier to see in the handle. So I teach a series of classes on this. They're called Joint, Bursa, and Tendon. It's a set of 3 classes, 4 days long each. The first class deals with all the joint capsules, bursas, and tendons of the upper limb. There aren't many bursas. There aren't really any bursas in the hand. The first one is at the elbow, but not to worry, there's a fine collection of bursas at the shoulder. And there's enough there that's 4 days to work through all of that. And the second class, 4 days, is similarly with the lower limb, again, starting with our toes and working our ways to the hip. I mentioned how the hip joint capsule was the first one that I ever worked with. It's in under a bunch of big, strong muscles and tissue, and little did I know that that's not the easiest one to get to. So we'll work up to that, but it's actually quite doable. And then the third class is axial. All of the joints, bursas, and tendons in the torso and neck. There are significantly fewer tendons in that area, but bursas in some interesting places. There is a bursa over the tip of each spinous process in the spine. And there's one right over the Adam's apple here. And of course, lots and lots of joints to work with in that territory. So for information on upcoming classes about this, you can find my Facebook page and private message me there, Jeffrey, Jeffrey Burch, or you can email me at jeffrey@jeffreyburch.com. Again, Jeffreyburch. Thank you.